can share in most of the savings provided. Again, Dartmouth is leading the way in these efforts. Medicare, while I was CMS administrator, started a demonstration program at 10 multi-specialty group practices around the country, including the Dartmouth Hitchcock Clinic right here at Dartmouth, to provide this kind of system. And under this approach, Dartmouth Hitchcock and the other participating groups report on how their patient population that their multi-specialty group practice treats is doing in terms of a range of preventive care measures, like using flu vaccines effectively for patients where it's indicated, using preventive tests for cancer effectively, and also measures of quality of care for the 6 or 7 chronic diseases that account for most Medicare costs. It's not that complicated. These are conditions like heart failure and diabetes and chronic lung disease that account for most Medicare expenditures. And the group's reporting not only on those so-called process of care measures, but also on outcomes for the patients with these chronic conditions, and also on some standardized patient satisfaction measures. And if they document improvements in most of these measures of quality, Medicare is also tracking the overall cost that Medicare is paying for their care. And if they document improvements and reductions in the overall cost trend in Medicare, they get to keep a significant part of the savings above a threshold. So I hope you can see that this changes the way that support for efforts like those thoracic surgeons that I mentioned earlier, changes the way that support for their efforts works. Now, under this kind of system, if you take steps like investing in an electronic record system so that you don't have to order so many lab tests and that you don't have to see your patients so often, and maybe you can keep them out of the hospital or even out of your office, or if you invest or if you hire a nurse practitioner to help your most challenging patients with chronic diseases stay well and head off complications, well, now it actually makes financial sense in Medicare. Under the old system, all that would happen is that you would have fewer visits, you would have fewer lab tests, Medicare would pay you less, and it would be harder to make ends meet in your practice. Now it makes financial sense because you can share in the savings from those kinds of reforms. So my hope is that by building on these kinds of efforts and payment reform, and Medicare and also some private sector payers are doing this as well, we can provide a much better support for the kinds of healthcare reforms that we really need. We also need to take steps to develop more evidence on what works to help drive better care decisions by healthcare providers. As many of you know, since Dartmouth has led the way in these kinds of studies as well, more than half of all medical practices, according to many estimates, are not evidence-based, particularly those practices that account for the big variations in the use of medical services that researchers right here at Dartmouth have identified. Unfortunately, it's hard to study these kinds of variations in practice in traditional randomized controlled trials. Typically, the reason that practices and utilization varies from area to area is not because of any one specific intensive procedure or any one